Thank you very much. It's not fair to give a presentation after such a talk, but I will do my best. Two comments. First, spinal cord stimulation is not the classical form of treatment for freezing of gait. It's not approved. This is something we should keep in mind. And the insurance companies are not reimbursing this technique for freezing of gait. There is limited experience. In the University Hospital of Cologne, where I used to work for 12 years, we operate on 3 or 4 patients. All of them had neuropathic pain, and on top of that, they had Parkinson disease and freezing of gait. So we could see if it could work in such a context, and it worked, not perfectly, but it worked partially. And the second comment is that it's a big presentation. I'm going to go through these slides pretty quickly because I would like to show you some videos in that. If you are interested in the topic, please let me know. I can send you my presentation. My conflicts of interest, I am or have been consultant for all of these companies. We are going to speak, of course, about freezing of gait, about how neuromodulation, especially spinal cord stimulation, can help patients with freezing of gait, and I'm going to show you the future trends. There are many definitions for freezing of gait. My favorite one is the last one, a sudden and transient motor block of locomotion that feels like feet are sticking to the ground. And this is something that the patients are describing, and it sets the diagnosis. Actually, it is an uncoupling of intention to walk from triggering of anticipatory postural adjustments, APAs. Often results in knee trembling and failure to initiate gait. There are some triggers, for example, turning movements. There are some relief factors, auditory or visual cues. We have some epidemiological data in patients with Parkinson's disease. It affects men and women, typically older adults. In early PD, 7% of patients develop freezing of gait. In moderate stages, up to 50%. In advanced stages, up to 80%. And then we have some special forms. For example, the Parkinsonian type multiple system atrophy, where almost 90% of the patients have some form of gait or speech or both disorder. We have also this primary progressive freezing of gait, now known as PSP-PGF. It's rare, and for me, it's really important that more than 50% of the patients are wheelchair-bound after 5 years. Which is the clinical consequence of freezing of gait? We have falls and injuries and trauma. The quality of life is reduced. We have functional limitations. The daily activities are influenced. We have psychological impact, depression in many patients, also in the families of the patients. And we have other symptoms like fascination, these rapid steps. Pathophysiology, I'm not going to go through all these things. If you are interested, I could be more than happy to send you this presentation. There are lots of things here, but it seems we have a brain circuit dysfunction at the level of the basal ganglia, at the level of the frontal cortex. We have connectivity abnormalities. We have brainstem and cerebral involvement. We have this PPN, this pentaculopondine nucleus. We have MLR, mesencephalic locomotor region abnormalities, and many more. We have motor control deficits with these APAs. Actually, here we have a failure of exact coupling between preparation phase and voluntary step. Gait pattern changes, higher cadence, smaller stride length. Oscillatory activity changes, changes in alpha and beta oscillatory bands, which correlate with gait performance. We have spinal cord mechanisms. We have a disrupted CPG, these spinal pattern generation centers. We have defective feed-forward and feedback loop mechanisms and inability to integrate multifactorial stimuli for complex walking behavior. We have a multifactorial integration failure. We know that there are sensory, motor, and cognitive aspects in the whole story, and it is required to have an integrated processing of frontal lobe for motor, cognitive, and limbic input. We have attentional and cognitive factors, which are also very important. We have excessive recruitment of lateral premotor areas. We have loss of automatic motor control, attentional deficits, cognitive overload, dual tasks. Pharmacological interventions, I think you are experts here. You know that better. For me, we have limitations with all these medications. Physical therapy can help, especially if we combine physical therapy with visual cues, auditory cues, proprioceptive or haptic feedback and rehabilitation strategies with emphasis on compensation strategies training. And now let's talk about targets. What should we target? We could target the cervical area, the thoracic, the lumbar, the dorsal column fibers, the dorsal root area zone area, or we can combine supraspinal and spinal targets with these brain-spine interfaces. Hopefully it's not boring. Treatment. We have non-invasive things, we have invasive things. Invasive things, of course, deep brain stimulation, and now probably, possibly spinal cord stimulation. Non-invasive neuromodulation, transcutaneous magnetic spinal cord stimulation, transcranial magnetic stimulation, transcranial direct current stimulation, non-invasive vagus nerve stimulation, and all of these modalities have been investigated with variable outcomes. You can find many publications. Deep brain stimulation works at the level of the third neuron. You know the targets could be STN for freezing of gait, PPN. We have mixed outcomes for freezing of gait. Initially, freezing of gait is improved, but the effect is less sustained. Spinal cord stimulation, together with intrathecal opioid therapy or non-opioid therapy, is working at the level of the second neuron. And spinal cord stimulation, it's not a new therapy. The first surgery took place in the United States in 1967 in a patient with a lung cancer. And the idea here is to implant 1 or 2 leads epidurally and stimulate the dorsal columns and the dorsal horns. We stimulate the alpha-beta fibers. Today, we have a much smarter technology in spinal cord stimulation. We have this closed-loop technology. What is that? The leads are stimulating. Because of the stimulation, the spinal cord reacts with generation of ECAPs, evoked compound action potentials. The leads can measure these ECAPs and adjust the stimulation real time so that the stimulation is optimal. How frequently can this system check these ECAPs? More than 4 million times per day. The mechanisms of action, here we must speak about direct neurophysiological effects, about connectivity modulation, about circuit level mechanisms, functional improvements, frequency dependent effects, anatomical considerations, and we have systemic versus local effects as well. I'm not going to go through this, especially not after lunch, but there are changes in brain activity. There is an inhibition of pathological oscillations, and the effect mimics dopamine replacement therapy or deep brain stimulation. We have a connectivity modulation. This is too much for now, but there is magnetoencephalography-based evidence. There is an interregional connectivity, and we have also a corticomuscular coherence. Circuit level mechanism, ascending pathway activation. We can stimulate ascending pathways, the spinal cord. We have brainstem modulation, probably at the pendaculopondine nucleus or the mesencephalic locomotor region. And we have also the central pattern generator, the CPG activation. We have functional improvements using spinal cord stimulation with these anticipatory postural adjustments. We have a sensory degradation. And there are some frequency-dependent effects. It seems that a higher frequency, let's say with 300 Hz, is much more effective than stimulating with a smaller frequency of 60 Hz. Of course, the pulse width plays a huge role. If we have large pulse widths, we recruit more fibers, more ascending systems. Then we have some anatomical considerations. Where should we implant the tip of our lead? It could be a T2, T4. At that point, the spinal cord is thinner, so it's much easier to capture more ascending pathways. Usually, colleagues are implanting the lead at T9, T10. But at that level, we must use bigger, longer pulse widths. We have the lumbar placement as well, and we could possibly also target the dorsal root area zones. Fiber recruitment, what type of fibers? We have dorsal column fibers. This is what we are usually stimulating for chronic pain patients, but we also have propriospinal fibers, posterior thoracic nucleus, Clark's column, for example, spinocerebellar tracts. There is an effect on suprasegmental circuits, the brain, rather than just local spinal circuits. And there is a synergistic activity, and this is important for future therapies, between the brain and the spinal circuits. We have immediate effects within seconds when we stimulate. We have changes, and we can document that in brain oscillations and motor initiation. We have chronic effects. We have a continuous improvement as long as the therapy is running over weeks to months after the implantation of the system. And we have also a short-term carryover effect, an effect that persists for almost 50 seconds after turning off the system. The link implantation could be at all these levels. There are publications about all these levels from T2 to T11. We can use percutaneous leads. We can use paddle surgical leads. Frequencies from 20 Hz to 300 Hz, pulse widths from 90 to 500 microseconds, and amplitude from 105 to 120% of the sensory threshold if we're using a tonic stimulation with paresthesias, or 50 to 30 to 70% of the sensory threshold if we're using burst stimulation. For the future, we need technology development and advanced electrode design, stimulation paradigms with burst stimulation, high-frequency stimulation, combination of these weapons maybe, and closed-loop systems. You know brain-computer interfaces. There's also these computer-brain interfaces. In this way, we can send information to the brain, actually write information in the brain. Other technologies that we have at this point are these brain-spine interfaces with combined supraspinal and spinal neuromodulation, targeting DREZs, and we can combine, of course, spinal cord stimulation with deep brain stimulation. And this is a study from clinicaltrials.gov, patients with deep brain stimulation systems, STN as a target, and a company, specific company, this surrogate company, use specific software using the existing leads in the brain in order to treat freezing of gait with good results. Meaning, let's suppose you have a patient with a deep brain stimulation system or a spinal cord stimulation, which is already implanted for indication A. Simply by changing the software in the battery, in the neurostimulator, we can treat at the same time with the same hardware another indication. This is the future. This video comes from the specific company, Surrogate. Have a look at the legs of the patient. In the beginning, we have a low cadence, and as the stimulation progresses, you see this higher cadence. It takes some seconds. And now you see the legs are moving faster. We have to find the optimal target. Is it T2, T4? This is the new trend, as a new hotspot, or something else. We can compare. Is it better if we implant the lead on the cervical area, or in the thoracic area, or in the lumbar area? Dorsal root ganglia, maybe. This could be another target. And we have to have some protocols about the frequencies. Is it tonic stimulation, high frequency stimulation, and so on. We need studies, but we need studies with at least 50 participants, so that we be sure what we are talking about. We need blinding strategies. We need patient selection to define clinical phenotypes that best respond to spinal cord stimulation, for example. We have to have a good sense of this mechanistic way of working. We need neurophysiological studies, for example, wearables, magnetoencephalography, biomarker development, functional connectivity metrics, comparative mechanism studies, spinal cord stimulation versus DBS, or maybe both of them at the same time. The combination approaches is neuromodulation, spinal cord stimulation, or DBS with rehabilitation and visual or auditory cueing, multi-site stimulation. We could have spinal cord stimulation with STN DBS or spinal cord stimulation with PPN DBS. We can have a sequential or simultaneous activation on one side, unilateral, on both sides, bilateral, and pharmacological interactions. Unlike DBS, spinal cord stimulation does not appear to potentiate levodopa. Extended follow-up, it would be nice to have follow-up of 12 or 24 or 48 months, and we need to have, for the insurance companies as well, quality of life metrics, the improvement of the daily activity of the patients. We have some disease-specific applications. I told you about this MSAP. or there is also the pure akinesia with gait freezing, dopamine-resistant Parkinsonism, early-stage disease or late-stage disease. All these things are really relevant, and we can expand to other conditions, for example, other Parkinsonian disorders with fog, post-stroke fog, and spinal cord injury-related gait disorders. We need minimal invasive approaches, closed-loop systems with the integration of biomarkers. We need a standardization, how we operate, where we implant the leads, what type of stimulation we're using, which frequency, which pulse width, outcome measures with questionnaires, for example, the specific questionnaire for freezing of gait, the new version of it. We should talk about the cost. This is a prerequisite nowadays, and we have to select patients, and we should have algorithms to select these patients for equitable access. Patients must be educated, and they must recognize the complications, and they should be able to use the devices we're implanting in them. If we move a step forward, other possibilities are advanced DBS therapies, but I think you know that better than me, so I will move on. Better pharmacological approaches with non-dopaminergic targets, with neuroprotective strategies like mitochondrial function enhancers. There are such drugs as well. Precision medicine with biomarker-guided therapy selection, and many, many other things. Non-invasive, most of you here are neurologists, you know about all these possible treatment modalities. Neurohabilitation, we can use virtual reality. There is this gamification of gait theory. We can use sensory augmentation. We can use wearable technology. We can have robotic-assisted training. We have gene therapy, optogenetic approaches. We can have cell therapies, combined cell and growth factor therapies. We need exercise for these patients. We need cognitive training, and especially this multitasking skill development. We need nutrition and supplements. There is lots of discussion now about this gut microbiome. Real-time MRI guided procedures, focus ultrasound, PET-based approaches to identify metabolic patterns, predicting treatment response in specific patients, brain-body interfaces, closed-loop brain-body feedback systems, synergistic therapies, multiple neuromodulation modalities simultaneously, spinal cord stimulation and DBS, for example. We have digital health, artificial intelligence with machine learning applications. This digital phenotyping is the term in the literature. Decision support systems with real-time adjustment, suggestions, and remote monitoring. We can stimulate cerebellum as well. We can target specific cerebral nuclei. We can use vagus nerve stimulation. We can stimulate before rehabilitate. We can have this motor sequence learning. We need network-based approaches. This is why we need this connectivity that we heard about. Chronotherapy, we can have time of day specific treatments. In the morning, one treatment, in the evening, something else, maybe. We need shared decision-making tools, so we have to have individualized goal-setting frameworks, self-management technologies, peer support networks, predictive biomarkers like electrophysiological signatures, monitoring biomarkers, real-time fog detection, international consortia and transnational pipelines, and case. All these videos that you are going to see today are online. I have the QR codes, you can scan them, you can download the videos, or I can send you the presentation. This patient, a female 66-year-old with PD for 15 years, with 22 points on this fog questionnaire. After spinal cord stimulation, this questionnaire scored 6 points, stimulation with 260 Hz, so higher frequency. We have a patient with multiple system atrophy with predominant Parkinsonism, you see before and 6 months after. And if you have a look at the PET, you see that after spinal cord stimulation, by the way, the surgical lead was placed with the TPT7, we had a 60% improvement in the fog questionnaire. So it seems that spinal cord stimulation can help. And this is a little bit longer video, 2 minutes or less. This is the baseline, how the patient is standing up and walking. This is without any stimulation. This is baseline. Have a look how she's turning. And I don't know if I can move it to save some time. This is the simulation, transcutaneous magnetic stimulation, and you see how she's standing up and how she's walking immediately after the transcutaneous magnetic spinal cord stimulation. I must admit the difference is not huge, but there is a difference. And 1 week later, you see the effect is diminishing. The result is not that good after 1 week. And this is a case series, only 5 patients, 68 more or less years old, with PD stage 3 or 4, 12 hours without any Parkinsonian drug, stimulation at T5, transcutaneous magnetic spinal cord stimulation again, 3 sessions with a 60 minutes interval, and each stimulation session consisted of 20 theta burst strains at 5 Hz. You see, with the red cycle is the freezing of gait questionnaire. You see it's statistically significant only for the first week, 7 days. After that, it's not statistically significant anymore. For me, spinal cord stimulation and deep brain stimulation is like music. It's a way to speak to the brain. Music is tones or sounds. Spinal cord stimulation, deep brain stimulation is electrical impulses. And if we are talking about intrathecal therapy, medications could be used as nodes for the nervous system. Above all, it's a dance with the patient. So we really have to pay attention to the patient and learn to dance with him or her. To sum it up, the future of folk treatment lies in personalized multimodal approaches, combining technologies. We can have non-invasive options or minimally invasive interventions with closed-loop capabilities. These options should be network-based rather than single-target strategies. We can integrate artificial intelligence, digital health. We must place emphasis on neuroplasticity and rehabilitation enhancement. It is a disease-modifying approach rather than purely treat the symptom. We simply have to find a way to turn on the light for these patients to walk better.
Even in the darkest of time, one only remembers to turn on the light.
Maybe spinal cord stimulation and DBS together could be that light for these patients. If you're interested in these subjects, you could have a look at these books. If you're interested in spinal cord stimulation and philosophy or art, you could have a look at that. If you're interested, let me know. I can send you the PDF or Word files for free, of course. If you're not members of the International Neuromodulation Society, I would strongly advise you to become members. This is the official journal of INS, Journal of Neuromodulation, with an impact factor of 3.5. These are the social media accounts of the journal. You can subscribe. If you have any questions, I don't think we have time to answer them, but this is my email address. Please free to contact me anytime. Thank you.
Thanks, quite a lot, George. Quite a lot of things to be clarified in the future, right? No comments.
Most of them, I would say.
Do you have any questions? I don't think that we have actually answered this. Yeah, you have one? Yeah?
For a great talk. Can I ask you, have you ever tried this procedure, spinal cord stimulation to neurological disease that have mainly freezing as the most debilitating complaint and symptoms, such as the primary freezing of gait, or tauopathies? A number of tauopathies actually have very debilitating freezing and refractory. Have you tried it?
Thank you for asking this question, especially after lunchtime. So I gave the answer in the beginning of my talk. No, we have not tried because it's not an FDA-approved indication, and the insurance companies are not reimbursing them. So we cannot try. The cases that I show you are based on the literature. You can find all of them on PubMed, the videos as well. I can tell you from our experience in the University Hospital of Cologne that we tried it only 3 or 4 patients, but the patients had mainly neuropathic pain, but it was a coincidence. They also had PD and freezing of gait. But we didn't have to justify to the insurance companies why we did a spinal cord stimulation in such patients. Now, if the question is if I have a patient with pure neurological problem, this freezing of gait, I don't think we are allowed to do spinal cord stimulation. Or we are allowed, but the patient should pay out of his or her own pocket.
Right.
Do you think this will cost?
30 to 35,000 euros. Yes, please.
Steve.
Thank you for the talk. I'd like to ask if you have any experience with transcutaneous stimulation or cortex stimulation combined with SPS.
No, because in Germany where I used to work, this was the field of neurologists. So neurologists were doing such things. And even when these things did not work out for the patients, only then the patients were referred to us for more interventional things. So I don't have any personal experience with this.
I have some patients with NSA or secondary ataxia that have preliminary data. They're doing quite well with transcutaneous stimulation.
The question is, how long does the good effect stay if you stop this therapy?
Right.
We don't stop the therapy. It's invasive. It's invasive with electrodes.
Okay.
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 I want to ask if you can combine maybe this peripheral stimulation, the kind of peripheral, with SCS.
Yes.
Okay.
Yes, we can. And this is the future to combine different therapies acting at different targets, because now we are seeing all these problems as a network problem, and we are trying at the same time to influence different parts of the network, not only one part of the network. This is the future.
Perhaps we need to proceed, actually. All right, then. Thank you very much, George.